Hello and welcome back. So now we've already seen how to do the overall robotic setup, opening the left atrium, performing a surgical ablation known as the Cox-Maze procedure. Now let's begin looking at mitral valve repair. The very first step at mitral valve repair is performing an annuloplasty. There are many different ways of doing different rings, and we're going to walk you through 3 different cases. First is a flexible band, the second is a semi-rigid band, and then the third is a circumferential rigid ring. Let's have a look. Let's start with a flexible posterior annuloplasty band. It's important to keep the holder, to keep the size intact. First and very most important bite is the trigone bite. This is the fibrous trigone, starting with the posterior medial. And then the next bite can often be challenging. It's important to use the dual blade dynamic retractor to help facilitate. This is not a rigid retractor, but a dynamic one. The first bite can be facilitated left-handed or right-handed, followed by each bite, in this case using interrupted suturing technique, to then help support each subsequent bite. These are then placed through their sewing ring first, and then through the annulus. Obviously, this is after the repair has been completed, which is slight different separation from endoscopic techniques where the sutures are placed first and then the ring is placed. The good thing about robotic surgery is you can really be sure you have a competent valve before even placing the annuloplasty, and the annuloplasty is supportive. But the key principles are the same: posterior band with the posterior medial bites first, and then transitioning to the anterior trigone and commissure. Testing the valve first before placing the first commissure bite is, I find, very important. And that allows for really seeing that trigone exceedingly well. This is often a failure point if this is not seen properly or placed properly. So that first bite is really critical. I then switch again to the left hand using the DeBakey as a needle driver to place the next few bites, both precisely, but also relatively easily without having to switch between needle driver and DeBakey. This continues. You can see there's been already a valve repair done in this case to really get deep, but precisely. Of course, this is the region we are right now between the left atrial appendage and the annulus where the circumflex lives. So not too deep, but deep enough. In this case, then switching back to forehand. And remember, the true annulus is 5 millimeters at least deep to the hinge point. Where you see that hinge point between the valve and the atrium is not the annulus. The true annulus is 5 millimeters deep to that. So the bites have to be deep, but most important, perpendicular, each bite. Once the sutures are placed, suture fasteners are then delivered from the table side through the working port or working incision. And note my right hand here. I'm pushing the atrium in. This is important so that the placement of the annuloplasty is truly sitting on the hinge point and not on the posterior leaflet. This is a common situation that occurs where that last moment you've done all the work, but then the tissues relax and the sewing ring ends up on the posterior leaflet. In this case, it's truly on the hinge point. The sewing ring is removed and the flexible band is complete. Now let's look to a semi-rigid band. A valve repair has been completed. We'll get to that later in future episodes. And now this is a semi-rigid band. Again, placing the semirigid band into the trigone as the first bite. In this case, it has a medial facing flute that's important to place. This is what's called the future band. The bands itself are not important. The principles are what this is all about. This semirigid band does allow it to lift up, almost like a toilet seat or a similar analogy, to allow these bites to be placed nicely and have some traction and counter traction, if you note the movement on my left hand. By doing so, it allows interrupted sutures to be placed, and sometimes you may need to let go of the sewing ring to grab your bite. But it's very important, as I've already said, to make these deep and in the true annulus. Now to the anterior trigone. Again, filling the valve. Sometimes with jet lesions, it's difficult to see where the true trigone is, and this is a good way that we feel truly identifies the tissue. Remember, in robotics, it is a visual tactile feedback, not true tactile. So these types of visual cues are very important. Switching again to the DeBakey in the left hand allows for that precision, but using the same principles, lifting up the sewing ring as a anchor and counter anchor to truly get that bite. And you can truly now see where the annulus lies. And this also allows for flipping it down to know where the actual entry point is perhaps best. And the last few bites, one can see. Now, in all annuloplasty placement, it's usually the posterior medial side that one might need to do the most reduction, with minimal reduction on the anterolateral side. But that's up to the surgeon and the annular dimensions noted. One of the goals of robotic surgery is to make sure we place the largest possible annuloplasty to give the best long-term result. Once secured, the valve is tested to assure competence. Now let's focus on a circumferential rigid ring annuloplasty. A valve repair has been completed, and this is important. All of the manufacturers of the prostheses mark the commissure on circumferential rings, the same thing in bioprostheses. They do not mark the trigone. The trigone is located central to where these markers are. A common mistake is placing the trigone where the commissures are. That's not anatomically correct, in my opinion, of course. So the placement we tend to prefer is do the anterior surface first, going from anterior to posterior trigone. And of course, at the anterior trigone, as you saw in the previous cases and this one, we tend to fill the heart to avoid any potential risk to the aortic leaflet. Now, finally, is the posterior trigone, and that's completed. An option is you could secure these with suture fasteners, but with good tableside assistance and organization, it's relatively easy to do without that. So now this is the true commissure that lines up with the commissural marking on the circumferential rigid ring. And using the sewing ring and the sutures placed, one can then approach posteriorly. And truthfully, all patients' anatomies are slightly different, whether you use left-handed or right-handed techniques. But the important thing is to line up the commissure to the commissure marker and the trigones where they belong. After doing one bite beyond the trigones, one can secure the anterior leaflet component. And now you're one stitch beyond to make it a little easier. Then you can use it to flip the sewing ring up to allow for good annuloplasty sutures that are deep and appropriate. Now, of course, there are techniques of running annuloplasty and things of that nature. We tend to prefer a interrupted suture placement technique that mimics true open techniques. Now, you'll note here, and perhaps on the previous one, there's a retraction stitch placed a priori in the annulus. Once this is reached, it can be broken very easily, but it allows for splaying of the tissues to truly see where the annulus lies, because sometimes in a dilated atrium, it can be a little difficult to sometimes see the true annular area or the hinge point. Noting again, you can see the depth of that bite is to the point where we know that that's going to be a deep point into the true annulus. Again, the needles being perpendicular to the tissues and entry, and use the curve of the needle to exit. Now, we prefer the use of a V4 needle, but of course this could be tailored to the surgeon and institution as long as the principles remain the same. Noting again how this is placed on the atrial side and not on the leaflet side, as the suture fasteners are being done with gentle pressure. And the valve is now complete. With a circumferential annuloplasty.
So now we've seen how to perform mitral valve annuloplasty. Flexible, semi-rigid, or rigid rings. Remember that all pathologies are somewhat different, and we have to always tailor our operation to fit the pathology and the patient. With that principle in mind, let's now begin in the next episode of how to start the process of primary degenerative mitral valve repair or mitral valve prolapse.